I too am delighted to be here and to thank Professor Karim for inviting me. It's my first time in Israel.
זו פעם הראשונה שלי בישראל,
It's a
ואני מאוד
wonderful
מודה
time.
על
I've been here
ההזמנה.
2 days now.
היה לי יום מאוד עמוס.
And I was asked to talk about how we treat cystic fibrosis in the United States. So
התבקשתי לדבר איך אנחנו
what I
מטפלים
wanted to
בזה
do was
בארצות
give
הברית.
you some ideas on how to be part of the team that's going to get you or your child the best outcome that you can get, the
אני רוצה
best
לדבר איך
lung
חלק
function,
מהצוות
best
כדי להגיע
nutrition.
לתוצאות הטובות ביותר.
So this is Johns Hopkins Hospital, the new children's center.
זה
The new
בית
children's
החולים
hospital.
לילדים בג'ונס הופקינס.
Just opened in May.
נפתח במאי האחרון.
Bloomberg Children's Hospital. The money was given by the mayor of New York.
Bloomberg. Okay, our child pavilion in Kerem, that's the hospital, is Bloomberg's also,
Also?
but his mother.
Yes, this is named for his mother. This is the Charlotte Bloomberg Children's Hospital.
Charlotte Bloomberg, okay.
There's a great emphasis on art. These are our puffer fish. I think they're going to have a contest to give the fish names. And we are now in a very exciting time at Johns Hopkins. This is the first year we have more adults than children.
אנחנו השנה הראשונה שבה יש לנו יותר מבוגרים מאשר ילדים.
This is our center over the years. This is
זה
children. This
המרכז
is
השנים,
adults.
הכחול
There's
בבוגרים,
almost
באדום
500
וילדים.
patients, about 225 children and 250 adults.
יש 225 ילדים ו-250 מבוגרים. קרוב ל-500 חולים מטופלים שם.
And I was also asked to talk about how we treat patients in the United States.
אז איך
I
אנחנו
think
מטפלים בחולים
these
באמריקה?
are the way we treat patients.
אלה
We do
הדברים.
airway clearance to try to mobilize the
ניקוז.
mucus, get rid of the
ניקוז של
mucus
איכה.
with devices
יש
or
לנו כל מיני
chest
מכשירים,
therapy.
פיזיותרפיה.
We use agents to thin out the
חומרים
mucus to
שעושים
get
תהליך
cleared better.
הפרעה.
You've heard a very elegant talk
שמענו
about
על
how using
פולמוזאין.
medications appropriately will make them work better.
ואיך להשתמש בהם שיעבדו יותר טוב.
And then we use antibiotics to treat the infection.
ואנחנו משתמשים באנטיביוטיקה לטפל בזיהומים.
So this is a very short talk, if I stop here. And this is what we do. This is what you
אני יכול
do.
לעצור כאן, כי זה מה שאנחנו עושים בסופו של דבר.
But the question is, how can you use this and make them better for you and your
אז איך אפשר
child?
להיכנס לזה שזה יהיה יעבוד יותר טוב?
You can really make a difference here. It's not, I put up here, genes are not the whole story. We talk a lot about the genetics of cystic fibrosis, but it's not all about the genes. It's a partnership between you and your care team.
בין
And it's about
החולים,
goals and
משפחות והצוות.
expectations, what you would like to have happen.
מה המטרות,
And then just a few
הציפיות.
words about the future and why this is important.
ומה אנחנו מצפים לעתיד.
So I want to talk to you about why everyone it's not all about genes. This is a study that we're doing at Johns Hopkins comparing twins and siblings with cystic
זה
fibrosis.
מחקר שהשווינו תאומים ואחים שהם לא תאומים.
And you know that twins and siblings are not all the same, but they have the same genes that cause cystic fibrosis.
בתאומים, באחים יש את אותם הגנים שגורמים ל-CF, אבל בתאומים יש הרבה מאוד גנים אחרים שהם מאוד משותפים.
And their lung function can be different, their nutrition can be different.
באחים תפקודי
And this study of 1,500 children and adults is helping figure out why that is the case.
זה מחקר ב-1,500 חולים שנסה להבין את ההשפעה של הגנטיקה.
And we compared in some studies almost 50 identical twins to
50 תאומים זהים,
200 or 300 fraternal twins and siblings to look at lung function.
לעומת אחרים
What's age match?
שהחיים
Age match means they're within 2 years of each other. The siblings that are within 2 years.
ששניהם חולים.
And I'm not going to show you all the data, I just want to show you one example because it illustrates what I'm trying to show you. These are a pair of identical twins, their lung function, their
אלה תפקודי
FEV1,
הריאות של תאומים זהים.
until they're about 20.
עד גיל
And
20.
they're very similar, they go up and down, but they're about the same. Then they both move away from home.
ואז הם יחזרו את הבית. הלכו לישיבה.
And the twins are now very, very different. One
ואנחנו
twin
רואים את
doesn't
זה.
show up, doesn't come to clinic very often. But the lung function is very different. So when you start comparing the twins to one another and the siblings to one another, you can find out that there are different influences.
שדברים שיש השפעות אחרות.
About half the explanation of lung function, where your lung function
חצי מהמצב
is your
של תפקודי
genes.
אפשר להסביר.
Your CFTR gene, but other genes as well.
אם זה הגן של ה-CF או גנים אחרים.
And about half is due to your environment.
וחצי קשור בסביבה.
In twins, about A quarter of it is common environment, something that they have together.
הירוק מראה את הסביבה
But
הזרה
a
להם.
third is actually what happens to them individually.
ובאדום זה הסביבה
So
המשתנה
you
שלהם.
all can influence this.
מה
You
שאנחנו
can't do anything
נשפיע
about this.
זה על משהו לא כחול. הכחול נקבע לנו.
So that's where the partnership comes in, and expectations. How can you influence that other half of lung function and nutrition? I'm going to talk to you about some goals from the Cystic Fibrosis Foundation. These just came out this year, but I really like them because it tells you what things to think about and what things may be important moving forward.
אנחנו רוצים לדבר על המטרות שאיגוד ה-CF האמריקאי הציב לעצמו בטיפול בחולים.
So what's goal number one? Goal number one is that people with cystic fibrosis and their families will be full members of the care team. You're part of the team. Communication will be open. Everyone will understand. Care will be respectful of CF needs, preferences, and values. You as a patient or a family are the most important part of this. Not the doctors, not Professor Krem, not all the other members of the team. So how do you do this? Well, you need to maximize your time in clinic. When you come to clinic, that's your chance to be with the physicians and the staff. To know what you want to be prepared. You want to know what questions to ask. You want to have, if you have ideas about making things better, you want to bring those forward. You want to ask your child about the issues that are affecting them, not only the issues affecting you. You also want to understand all the data that people talk about. You heard about some numbers. You need to understand and learn about lung function and weight and BMI as body mass index, another measurement of nutrition, about microbiology and infections, genetics, other labs and x-rays. You want to understand, make sure you understand those. What's the second goal? The second goal is that children and adolescents and adults with CF will have normal growth and nutrition. Why is this important? I'm going to show you a lot of data from the CF registry, which is a registry of all the patients in the United States. There's 27,000 patients that are categorized in this. The patients in Israel are also in a registry, not this registry, but a European registry. So this data is available for Israeli patients as well. This graph looks at BMI, which is a measure of nutrition. The 50th percentile is average. And then lung function, measured by FEV1, which is a measure of how obstructed the airways are. There are boys and girls. And you can see as you go below the 50th percentile, get below average, the lung function falls. And as you get below the 20th and 10th, it falls dramatically. It's somewhat of a chicken and egg phenomenon. You don't know which is causing which. You don't know if lung function is bad because the nutrition is bad, or nutrition is bad because the lung function is poor. But either way, it's better to be here than here. So this is talking about expectations. When I was trained, the goal was to be here. And we didn't really worry until you got down here. Now the goal is to be here. And if you have the expectation to be at the 50th percentile average, then you can change things. This is age, so I'm a pediatrician, so I'm talking mainly about children. But this is patient age, BMI, this is average here, and these are different eras. So these are patients in 1991, 2001, 2011. And with the idea that we're going to shoot for a higher target, things have gotten better. So the goal is to be here, and we achieve that on average for most patients. So the third goal is that CF patients will receive appropriate therapies for maintaining lung function. Pulmonary exacerbations will be treated aggressively, detected early, and to try to return people to their previous lung function. This is why this is the same goal, the same expectation idea. This is now lung function. And over the decades, lung function has gotten better as we've developed more therapies and started more therapies and been more aggressive.
בגלל שהטיפול יהיה יותר אגרסיבי ויש יותר טיפולים.
But there are things we know affect lung function. Exacerbations, where your patients become sick, become hospitalized, need to use antibiotics, have a dramatic effect on lung function. We all lose lung function as we get older. In cystic fibrosis, that happens faster than the average person. But it's not a straight line. It's a stair step. You get sick, it goes down, it goes down. This looks at the rate of decline of lung function % per year in patients that have exacerbations. This is again from the CF registry in 2003 to 2006, and this is children. The more exacerbations you have, the faster your lung function declines over the course of the year. In adults, the same thing is true, but not as dramatic. It's much more dramatic in children because they're starting from a better place. Their lung function is higher. So when we try to figure out what the best approach is to treating exacerbation, there isn't a lot of data. There aren't a lot of studies saying this approach is better than that approach. So there was a benchmarking project. So looking at where they looked at the centers with the better outcomes, and average had better lung function than other centers that had lower lung function. And what they found is the center that had better outcomes were more aggressive with their antibiotics, had higher expectations for what lung function should be, and didn't tolerate decline. They didn't say, oh, well, it went down, that's okay. Lung function went down, they treated aggressively, usually with antibiotics. So this is what the doctors are doing. And you too are trying to identify problems. But most of the care is not in the doctor's office, it's at home. That you're doing day in and day out. And as you just heard, that's hard to do. It's hard to do correctly. So I also am going to talk about adherence. This is a study we did at Johns Hopkins of 95 patients. It was published last year. We looked at how adherent patients were to their medicines. So this is a measurement of how often patients got their prescriptions refilled. So they actually got the medicines from the pharmacy. We don't know if they took it or not, just got it refilled. This is they refilled it at 100%, they got every refill. So if you were on a medicine you're supposed to be on hypertonic saline every month, you got it done 12 times. You got all your doses. These are ages 6 to 12, 13 to 18, and get to be adult. And you can see this is the average. 80% of children got the prescriptions filled. Some were better, some were really horrible. As you get older, adherence declines. So adults don't do as well. So when you look at adults, they're doing about 50% of it. And this is very important. Because the less adherent you are, the sicker you're going to be, the more exacerbation you're going to be. So this is again, how often you get your medications refilled compared to whether you were hospitalized in the next year. The patients that were hospitalized, the patients that refilled their medicines the most didn't get admitted to the hospital. The people that got admitted 1 or 2 times have worse adherence than the people that are admitted 3 times.
לקחו פחות מ-50% מכתתופות בבית. כלומר,
שכשלוקחים בבית המרקחת,
זה קשור בפחות החמרות, או צריכים פחות תרופה בבית החולים.
So when you look at lung function, over the course of the year, the people with the best adherence, which is here in the green, had a lower decline in lung function.
עכשיו, כאן אנחנו רואים ירידה בתפקודי הריאה, ככל שלקחו יותר את התרופה מבית המרקחת, הייתה פחות ירידה.
But I don't want you to look at this year, because the year is kind of boring. Look at where they started. This is a lifetime of adherence we're looking at, not just the year we studied. The people that had the best adherence had dramatically better lung function when we started the study. And if you think about the average person with cystic fibrosis losing 1 to 2% of lung function a year, this is years of lung function. Years of decline because of not taking your medicine. Lost lung function. So there's lots of barriers to adherence. There's
יש הרבה מאוד
understanding the
סוגים לקחת
medications,
התרופות.
anxiety,
להבין מה
financial issues,
התרופה,
behavioral
חשש מתופעות
issues,
לוואי,
schoolwork, other
כספיות,
commitments, time that it takes to
בעיות
do these therapies,
התנהגותיות, בעיות
stigmata of being sick and not
לימודים,
wanting to take
שלא
medications.
צריכים לקחת.
Your goal as this partnership is to be honest.
בשותפות הזאת
Doctors, everyone is very bad at guessing how much medication you're using.
או לא לוקחים.
You need to tell us that we can identify, are you doing your medicine correctly? Should you be doing something different? Should we change? We don't want to add more if you're not doing what you're already doing.
האם יש אפשר לעשות משהו יותר?
So what's the fourth goal?
אותה הרביעית.
CF patients are found to be partners with the staff about infection and reducing the spread of germs. You already are working on that now as I see everyone wearing masks in the room.
אני רואה שאתם עובדים על זה, אני רואה כאן מסכות באולם.
We know that Pseudomonas, which is shown here, this is again from the registry, age of the patients, number of people with a particular bacteria. About 80% of patients eventually grow Pseudomonas. Pseudomonas, though, is present even in young children. And we know that Pseudomonas acquisition is associated with a faster decline of life. So we spend a lot of time trying to prevent this and other bacteria from acquiring it and spreading the bacteria. I'll just show you this to remind you. I'm sure you all know that Pseudomonas is something that we are very concerned about. This is lung function here. It's a study from Sweden. And these are patients without Pseudomonas. And these are patients with Pseudomonas. The lung function declines more rapidly when you have Pseudomonas. In general, not necessarily for an individual person. So we try hard to eradicate it when we find it, and keep it under control when it become colonized. And that's true for patients that are pancreatic insufficient, that take enzymes, and for patients that are pancreatic sufficient that don't take enzymes. So this is without. So you can work to try to eradicate Pseudomonas and decrease the amount of Pseudomonas in the clinic. And I know you've had some focus on this with infection control. This is data from Denmark, where there's really, for the forerunners of trying to understand Pseudomonas and trying to decrease the amount of Pseudomonas that their patients have. These are different years of patients with different years where they looked at how many people in the clinic had Pseudomonas after they first acquired it. So when they first found with Pseudomonas, in the early 70s, they didn't do anything. So in the end, everybody had Pseudomonas. And then over different years, they tried different approaches. And as they became more and more aggressive, fewer and fewer people ended up with Pseudomonas chronic. So being aggressive and trying to eradicate and trying to control Pseudomonas is very important. The fifth goal is that patients with cystic fibrosis will be screened aggressively and treated for complications.
זה בדיקות אגרסיביות או תקופתיות חשובות לסיבוכים.
Understanding that things develop in CF over time as you get older is important. And that you and your care team need to look for these problems and treat them when they occur. This is age of patients here. These are different problems that develop in cystic fibrosis patients. Diabetes, which is in green, is about 40 or 50% of patients eventually will develop diabetes. Osteoporosis, depression, arthritis. There are many other problems that can develop, not necessarily will develop, but you need to be aggressive in looking for these and treating them when they occur. So that's where we are right now. I've talked to you about approaches to be proactive and to have expectations and goals. Well, what will the future bring? Well, I hope it will continue to bring this. This is survival in the United States, expected survival from the past few decades, so that every year, pretty much it goes up every year, so that people are living longer and healthier. I expect this will continue.
ואני צופה שזה ממשיך לעלות.
There are going to be many new therapies.
יש הרבה תרופות חדשות.
I maybe should have started with this. This is the CFTR protein sitting in the cell. As you all know, it transports chloride, it leads to thick, sticky mucus. And that problem leads to a whole cascade of problems. So, there's an abnormal gene, the salt doesn't go into the cells the way it should. You don't clear the mucus the way you should, you get inflammation and infection and obstruction and scarring that you saw. There are therapies to treat all these things going
יש
forward.
טיפולים בכל שלב ושלב של התפתחות
There's a
המחלה.
whole list of them here from the
יש
Cystic
כל מיני
Fibrosis
תרופות
Foundation.
חדשות שנמצאות
You don't need to worry about the
במחקר.
details other than to know that there's therapies for
רק
all
להגיד
these
לכם
problems.
שיש
For
הרבה תרופות
nutrition, for
שבשלבי
infection,
פיתוח.
for inflammation, for changing the mucus, for treating the basic defect, for treating
לטפל
CFTR.
בעריכה, שתהיה פחות סליגה.
I mean, that's the eventual goal, is to make CFTR function better and
המטרה היא
hopefully
שהתפקוד של
prevent a lot of the
החלבון יעבוד
problems we
יותר
talk
טוב.
about now. So that's the future. That's what we can be looking forward to
זה
as you stay
טיפול
healthy.
גנטי שיתקן את הפגם הגנטי.
So what can I leave you with? Cystic fibrosis care is very complex. It's very
טיפול
hard to
ב-CF
do.
הוא מורכב ומסובך.
You need to be partners in this
עולים, משפחות,
team to
הצוות
make it
צריכים להיות
successful.
שותפים.
There's no way that you can't do this as a partnership and have
ללא
success and
שותפות
optimal
זה לא
outcomes.
יצליח.
Most care occurs at home. You
רוב
come to the
הטיפול
doctor or
בבית.
the hospital for a very
לא
short
בבית
period
חולים.
of time. So you need to be honest with the physicians about what's going on at
חשוב
home.
להיות כנים ואמיתיים
You
עם
need to have
הצוות הרפואי.
expectations of what should happen at home that are realistic
לשתף
and that are shooting for really
ריאליסטי
optimal
לעשות בבית
outcomes.
ומה לא.
Together you can improve that, and there are things that
ביחד
you can do
אפשר
now
לשפר
to
את זה.
improve this that we've talked about. There are new therapies coming along
ישנה
that are
תקווה
going to
שבעתיד
have
הלא רחוק
dramatic
יהיו
effects, I
תרופות
think.
שיהיה להן אפקט דרמטי לשיפור ב-CF.
But they're not going to reverse damage. So the X-rays or the CT scans that Dr. Tidden showed you, that's fixed disease. Those
נזק שכבר נוצר
problems in
הוא
end-stage
קשה
lung disease
לתקן.
are not going to be reversed by future therapies. So prevention is the key to all this. Prevention and expectations are going to be what you should focus on now to stay healthy. And that's what I want to end with. Appropriate expectations,
ציפיות
aggressive
נכונות,
therapy and
טיפול
prevention
אגרסיבי,
are really the
מניעה,
key to
זה
achieving
המפתח
optimal outcomes.
לפתרון.
So, thank you. Happy to answer any questions.
זה הזמן לשאול שאלות. There's a question of a small infant that developed severe disease in early infancy. Can you see improvement later on?
In infants that develop small, severe disease in infancy, I think you can have some improvement, but some of that disease may be fixed, that it
אפשר
cannot
לראות
be
חלק
changed.
קצת שיפור וחלק בלתי הפיך.
And that's where trying other therapies may be helpful, but unfortunately, you don't know in advance until you try the therapy that they're going to make.
צריך לנסות כל מיני טיפולים כדי לראות מה יכול להפוך את הנזק שנוצר.
So maybe Peter can comment to that for the small airway disease, which we know very little, actually we see that it can be reversed. And about what we see, we know that about 1/3 for sure can be reversed. But for you said the CT on the left side, that is what you said, that cannot be reversed.
So I think when you think about cystic fibrosis, there's inflammation and irritation, there's mucus and infection, and then there's scarring. And when you get to scarring in the lungs, that can't be
יש
reversed.
דלקת, יש זיהום ויש צלקת. כשיש צלקת, צלקת זה לא
But many of these other problems can be fixed and can be improved upon. Thank you for coming.
תודה רבה, אתם מוזמנים לשתות, ואפשר לשאול את האורחים שאלות באופן פרטי, אתם מוזמנים.
Has almost the location.
That's what I heard.
אני הבאתי.